So today we will talk about the polycystic ovary syndrome. Polycystic means that there are multiple cysts in the ovaries, and PCOS is the most common endocrine disorder in young women. And PCOS is the most common cause of anovulatory infertility, and it accounts for about 80% of the cases. And PCOS is a syndrome of ovarian dysfunction, along with the cardinal feature of hyperandrogenism or hirsutism and a polycystic ovarian morphology. So PCOS contain three components. It involves ovarian dysfunction and include hyperandrogenism and polycystic ovarian morphology. And PCOS is also associated with increasing risk of type 2 diabetes and cardiovascular events. And PCOS affect about 5 to 10% of the women of reproductive age, while the prevalence is much higher on ultrasound, around 25%. And the etiology of PCOS is unknown, and it is likely to be multifactorial, means that multiple factors may be the cause of it. PCOS may be associated with the following factors, like it may be genetic running in the family, there may be insulin resistance occur, there may be hyperandrogenism occur, and it mostly the PCOS is usually associated with obesity, and obese female risk of PCOS is high. Now let's talk about the cardinal features of the PCOS. So the PCOS female are amenorrheic, or they may have oligomenorrhea, and similarly they are usually infertile, and they have infertility, and they count by about 75% of the cases. Similarly, these female have features of hirsutism, and they are also obese, and there is a feature known as acanthosis nigricans in these female. Acanthosis nigricans is the increasing area of pigmentation in the plexural skin areas such as axilla, and it is seen in about 2% of the cases. Now let's talk about the diagnosis of the PCOS. So no single test is diagnostic of PCOS. The laboratory tests include testosterone level. So testosterone level is elevated. There is decrease in the sex hormone binding globulin, and there is elevated luteinizing hormone level. The most important one is elevated FSH and LH ratio, and similarly there is also increase in the fasting insulin level. And similarly, we also do thyroid function test and prolactin level also in these female. And in radiological study, we do ultrasound abdomen. So in PCOS, we have more than 8 subcapsular follicular cysts that are more than 10 millimeter in diameter, and there is increase in the ovarian stroma. So the ultrasound may support the diagnosis of PCOS, but is not alone sufficient for the diagnosis. Ultrasound shows polycystic ovaries in about 25% of the cases, but not all of them have the syndrome. So in diagnosis, we have elevated testosterone level occur, decreased sex hormone binding globulin, elevated LH and elevated LH-FSH level, and there are positive ultrasonic findings occur. Now there is a specific criteria known as Rotterdam diagnostic criteria for the PCOS. So this criteria require the presence of two factors out of the following three variables. The first one is the PCOS female have either amenorrhea or oligomenorrhea, and the second one is they have the clinical signs of hyperandrogenism, like they have acne, hirsutism, or alopecia. And the third important factor is polycystic ovarian morphology on ultrasound, which shows more than 12 follicles in one ovary, and there is increase in the ovarian stroma, or the ovarian volume is more than 10 ml. Now let's talk about the treatment of the PCOS patient. So the first one is the lifestyle modification. So we advise the patient to adopt a healthy lifestyle, do regular exercise, decreases his weight, and take care of the diet and the nutrition. Regulation of menstruation, we give the patient combined oral contraceptive pills, and COCPs also increases the sex hormone binding globulin, so which decreases the androgenic symptoms. Now in case of infertility, for the induction of ovulation, we give different agents. The first and the most common is the clomiphene citrate. Similarly, we can also give the patient letrozole for ovulation induction, and if it is resistant to both these drugs, then we can do the laparoscopic ovarian dwelling. Now, for the hyperinsulinism and the cardiovascular risk factors, in case of type 2 diabetes, we can also give the patient metformin, which is a biguanide. And by the signs and symptoms of hyperandrogenism and hirsutism, we give different drugs. The first one is the epinephrine cream. So this cream inhibits ornithine decarboxylase, which is responsible for hirsutism or the hair growth. Similarly, we can also give the patient cyproterone acetate, which is an anti-androgenic drug. Similarly, we can also give the patient GnRH analog, uh, which suppresses the ovarian androgen. Similarly, we can also give the finasteride, and at the end we can also apply the patient surgical treatment like laser therapy and the electrolysis. Now let's talk about the long-term effects of the PCOS. The first one is the cardiovascular disease. So PCOS increase the risk of cardiovascular disease due to obesity, insulin resistance, and dyslipidemias. Similarly, in PCOS, there is increasing risk of type 2 diabetes and gestational diabetes. And due to a long period of secondary amenorrhea with resultant unopposed estrogen, PCOS patients are at an increasing factor for endometrial hyperplasia, and especially the endometrial carcinoma, which is the most common complication in PCOS female.